and some of it will go out the chest tube. So that's your bronchopleural fistula. All right, so 1, 2, 3, 4 reasons why you're not getting your volume back. Now you could be getting back more volume than you put in. So if more, and then I'll give you 2 reasons for that. All right, if you're getting back more volume than you put in, the first reason is because warmth and humidity expand a volume. Warmth and humidity expand a volume. So patient has an HME line. The air comes out of the piping system really cold, goes through the ventilator, goes to the patient, and the patient's body warms it up, saturates it with water vapor, and now once that's done, the volume has expanded. Usually about 50 mLs for every 500 ml tidal volume. So typically you should put in 500 and see about 550 mLs come back, only because the heat and the moisture expanded it. So that makes sense? Warmth and humidity expand a volume? Mm-hmm. And then the second one, air from a previous breath is being exhaled. Air from a previous breath is being exhaled.
So would that correlate back with the incomplete
Yes.
exhalation?
Yes. All right, so that was definitely more than 3 reasons. So next it talks about the graphic display. So when you're looking at the graphics on the ventilator screen is easy, it's big. When you walk in the room, you can see your graphics. And you'll see something like this if there's volume missing, where you'll see the volume go in, but when it comes back out, instead of touching the baseline, it's above the baseline. So that tells you you've got missing volume. And then, of course, the ventilator resets for the next breath and starts down at the bottom, puts the air in, but then it doesn't all come back out. So there's some volume missing. And then you can also see it from your digital display. You put in 275 mLs, and you only got back 215 mLs. All right, so this back in time video on YouTube, will it take us there? This is from 1969.
Wow.
YouTube was not invented. So here he is checking the order on the chart that says for him to make a change on the ventilator.
The attires, classic.
He walks in.
The attire.
Yeah, all respiratory therapists, when the profession started, had to wear a shirt and tie to work every day. Can you imagine that tie hanging in
I
secretions?
know. Oh gosh, things change.
That's the ventilator.
That's the ventilator.
Oh my
So it's an MA1.
Look at their little hats.
That's what I'm saying.
Yeah, you like the nursing hats?
Yeah.
The dark glasses or the thick-rimmed glasses? All right, so you don't get a digital readout on this ventilator. That's all you get, is this bellows filling with air with the exhaled tidal volume. So the air goes into the patient. When it comes out, it goes into this bellows spirometer, and that's how you know what tidal volume the patient is getting. Is that funny or what?
Oh my gosh, it's so.
You
I'm
see
glad I
chest
didn't get
rises.
schooled back then.
Look at, there's just a few knobs. Things were much
Yeah.
simpler back then. All right, so I just wanted to share that with you.
It's funny.
So this graph right here is abnormal. Would you consider? When
Yes.
it's not normal?
Yeah, you'd be able to look at that and say, I'm missing some volume.
Right, because it's not
So-
going to be.
You would check, what would you check?
Check the circuit.
Okay, so you would check the circuit for leaks, you do all your pushing and twisting, make sure
Troubleshooting.
everything's connected.
Check the cup.
The cup,
Bronchopleural fistula.
yeah. See if the patient has a chest tube in, maybe the air is going out the chest tube.
Right. See,
Now,
things.
if they did have one, then you can't really control that.
You cannot, that's correct.
And then incomplete exhalation.
We have to check the history, I guess, maybe? See
Yeah,
if
for
they
air
have-
trapping, yeah.
Air trapping.
check
So
their
if you
history
check the
to see-
patient's history and see they have COPD, that would
then you
explain
know
why.
that it's-
That's true. And so when you're checking the circuit, one of the common places for there to be leaks is the suction catheter. You know how you depress the thumb port to suction?
Right.
And then when you're done, you're supposed to turn it and lock it. Sometimes the patients lean on it or it gets stuck and it's stuck in an open position. So make sure that that's locked when you're done suctioning the patient. That's one of the typical places. Probably air leaking around the cuff would be another typical place that you lose volume. Okay. All right, the next setting is respiratory rate. So it tells you a normal respiratory rate for adults is between 12 and 20 breaths per minute. A respiratory rate multiplied by the tidal volume will provide a minute volume. We talked about that already. A sufficient minute volume will maintain a PaCO2 of about 40 millimeters of mercury. So, it'll give us some examples coming up on the next slide. So volume and respiratory rate will affect ventilation. If the PaCO2 is low, so you draw a blood gas and you see that the CO2 is less than 35 millimeters mercury, what is your recommendation for a ventilator change? You want the CO2 to be about 40. What would you have to do?
Respiratory rate?
Increase the respiratory rate?
No, decrease.
Yes.
Decrease for this
Decrease
shape.
the respiratory rate, and that'll allow the CO2 to stay in the blood and not be exhaled,
Yeah.
and then the CO2 level will come back into normal range.
Because we increased it, then it'd go even lower.
Then they'll leak
Yes.
more.
Very good.
More of a problem.
Yeah, that's the connection I want you to have. So less ventilation, CO2 will climb. More ventilation, CO2 will drop. So did we already answer the second bullet?
Correct.
If
Yes.
the CO2 is high, it's greater than 45 millimeters mercury, what is your recommendation for a ventilator change? Increase the rate. So you wrote down decreased rate for the first one, increased rate for the second one. But what else affects ventilation other than just the rate? Yes, the tidal volume also affects ventilation. So you could say tidal volume and respiratory rate affect ventilation. However, what if you've already set the tidal volume perfectly for that patient? You already have it in your 6 to 8 ml per kilo, and you see that the CO2 is high. Would you recommend increasing the tidal volume to improve ventilation?
CO2 is high?
The CO2 is high. Would you increase the tidal volume?
I'd increase the
I guess
respiratory
not.
rate.
Perfect.
Exactly. So yes, it's true that if you increase the tidal volume, you increase ventilation and you'll get rid of CO2, but you want to keep your patient's tidal volume in their normal range, the 6 to 8 mLs per kilogram. So can you see how the question could be asked differently? So your patient's in the hospital, they're on the ventilator, you've got your blood gas, and the CO2 is high. You've got two choices, increase tidal volume, increase rate. What are you going to check first before you make a recommendation? You want to make sure tidal volume is in the normal range. And if it is,
Then increase rate.
then increase the rate.
So
What if it's
Take it out.
on the, like, for the tidal volume, what if it's on the lower side of the normal, 6? You increase it to 7?
You could potentially increase it, yeah.
Then you'd have to be monitoring the different loops to see if there's too much compliance or something.
You could check the compliance after you've changed the size of the tidal volume, true. But typically you'll look at airway pressures. If you're putting in too much volume, your pressures will go up.
Right. About 30.
And then I have the same question worded all different ways. What if the tidal volume is increased? What effect will that have on minute ventilation?
The tidal volume is increased. And they have a high respiratory rate.
What effect will it have on minute volume if you increase the tidal volume?
It'll increase it.
Yeah, increased tidal volume will cause increased minute ventilation. If the respiratory rate is decreased, what effect does that have on minute ventilation?
Minute ventilation decrease.
Yes, minute ventilation would decrease. It's all the same thing, I'm just asking it in different ways.
It's all.
We're gonna go about 10 more minutes, Julian? All right, so the next setting on the ventilator is the flow rate. We can tell the ventilator how fast to push the air into the patient's lungs. It asks you how fast is a normal flow rate for spontaneous breathing. So now sitting at your desk, you breathe in, how fast does the air go in? And the answer is about 30 liters per minute for adults. When you breathe in, if you were to measure your flow rate and how fast you breathe in, it's about 30 liters per minute. When you put a patient on a ventilator, instead of starting with 30 liters a minute, you start a little bit faster than normal spontaneous breathing, and that would be about 40 liters per minute. So initial setting on the ventilator, about 40 liters per minute. And then I want to tell you the range for the flow rate on the ventilator. 40 liters a minute up to, pardon me, up to 120 liters per minute. That's fast.
So for initial setting on ventilator,
40 liters a minute,
to 100.
but peak flow can go up to 120 liters per minute.
Under what circumstance would you put it so high?
Somebody who has severe air hunger, so they're pulling really fast and you're trying to get the air in to meet their needs,
Right.
then you would increase the flow rate to get the air in faster. So if they're breathing really fast, increase the flow rate to get the air in faster. The peak flow rate is indirectly set on the servo ventilators. So when you walk over to a servo ventilator to set the flow rate, you're not going to find that. What you are going to find is the I time, or inspiratory time. So inspiratory time is the amount of time it's taking for the air to get into the lungs, the inspiration. And if you choose a short amount of time for the air to go into the lungs, it's going to go in there really fast. So does that make sense for the next bullet? Or the last bullet, I guess I did it backwards. A fast flow will shorten inspiration. So if you push the air in really fast, you're going to have a short inspiratory time. But if you let the air go in slowly, it's going to have a longer inspiration. Makes sense, right?
Yeah, yeah.
All right, how will you know the flow rate has been adjusted properly? Well, it must be in sync with the patient's needs. So as they're breathing in and out, you want to set the ventilator to meet their needs. So you don't expect the patient to do what the ventilator is doing. You want the ventilator to do what the patient is doing. So if the patient is breathing fast, you want to deliver the flow fast to them. But if they're, it's an 80-year-old lady on a ventilator and she's got small tidal volume, she's breathing slow, and you don't need to push the air in really fast. Now you can have a little longer inspiration. So you just look at their breathing and then adjust the ventilator to match their breathing. Flow rate determines IE ratios. And I don't know if we'll get to IE ratios now because time's up, but we'll get to it next week. That's comparing the amount of time for inspiration to the amount of time for exhalation. And then typically you need twice as long to get the air out as you put it in. That's all I'm going to tell you today, so we can discuss it next time. Did you know that a flow rate too fast causes increased airway turbulence? So if you push it in too fast, what do you think is going to happen to the airway pressure?
It's gonna increase.
Yes, it will go up. Very good. A flow rate too slow causes asynchrony with the patient and inverse IE ratios. That doesn't make sense to you today, but it will shortly. All right, we can stop after this one. It says shortening the I time. A patient on the ventilator has a 500 ml tidal volume being delivered to his lungs. When the inspiratory time is 1 second, the peak airway pressure is 26 centimeters of water. When the inspiratory time is changed to 0.8 seconds, so they shorten the I time, the PIP increases to 30 centimeters of water. Why does this happen?
Pressure to go that fast.
Yes. You need more pressure to push the air in faster. Or should we say more pressure builds up when you push the air in faster? All right, so should we stop there? All right, Martine, you know how to stop the recording?
Oh, yeah.